from the Washington, D.C. area. It's the Inside Scoop, all the news that our viewers want to know. Now, here's the host.
Good evening and welcome to the Inside Scoop. I'm Melissa Batchelor-Murphy and I'm your host for the Inside Scoop and the monthly healthcare series that we're doing. So June is National Patient Safety Month, and what better healthcare issue to talk about than patient safety? And I'm joined by Dr. Scott Betzelos, who's the Chief Medical Officer for the Inova Health System. And you're here to talk to me about all the great things that Inova is doing around patient safety.
Thanks, Melissa. Really excited to talk about the opportunity to talk about the patient safety issues that we're dealing with and how we are mitigating them and working forward in the organization to make our patients 100% safe and zero harm. I'm not the Chief Medical Officer for the system. I'm the Chief Medical Officer for Inova Fairfax Medical Campus.
Thank you for correcting
And I just want to make sure we get that straight.
Yeah.
But we began this journey of a high reliability organization about 2 years ago. And if you ask what is a high reliability organization, and you look at the word reliability, and reliability really means to get the same outcome from systems and processes that are already in place while multiple people use those systems and processes. Mm-hmm. So if you can get 100% reliability, then you've achieved the goal of no defects. So why do we want to become a high reliability organization? Medical harm is the third leading cause of death in the United States, right behind heart disease and cancer. And in addition to that, medical harm has infiltrated the medical community for many, many years. And since 1999, when the Institutes of Medicine published their book, To Err is Human, the medical community has done everything it can to reduce the opportunity for harm to exist in our processes. And so we continue to move towards becoming a high reliability organization. And the other thing about medical harm is that if you look at Six Sigma, and you look at the federal aviation industry, and you look at nuclear energy, they are at 6 sigma, which means 3.5 defects per million opportunities. Medicine is right around 3 sigma, which is about 65,000 defects per million opportunities. That's right along where baggage claim is, where your bag gets delivered by the airplane, as opposed to being 6 sigma, where you get from point A to point B without dying. And so that's where we really want to be at the 6 sigma level.
Okay. So when we talk about patient harm, what exactly are you talking about within medicine?
Patient harm can be anything from an error that occurs during a surgical process to a preventable infection, such as if you have a central line and you are accessing blood from that central line and you end up with a bloodstream infection, that causes harm to patients and can cause death and morbidity. The whole idea about high reliability is to use process standardization to reduce clinical variation, outcome disparity, and lower morbidity and mortality overall. So that's what we're trying to achieve by using high reliability principles to get us to where we need to go to reduce harm and to get to zero harm.
So what are some of the principles that you're using?
Well, one of them is a commitment to resilience, and that is really the ability for an organization to come back from something that got in its way, a barrier. Mm-hmm. And the ability for an organization to do that is really a good measure of its ability to retain and be reliable with its outcomes. And one of the things that we're doing at Inova Fairfax around a commitment to resilience is our safety review meeting. And we have this twice a week, and this is where people from the front line come and talk to us about harm that has occurred or near miss that has occurred.
Okay.
And they walk us through a root cause analysis, which is the 5 whys of why something happened. And we identify what happened, and then we try to put in mitigating solutions to prevent this from occurring again. So that's one example of what we're doing at Inova. We've been doing that for many, many years, and we've accelerated that process, and we're starting to put in other things in our safety review meeting that are around just culture, and we'll talk about that in a little bit. But the second one is the deference to expertise, and this is one of my favorite ones because really, as a leader in the organization, I don't have the answers to everything. And realizing that and recognizing that the person that knows how to reduce harm at the bedside is the bedside nurse, or the physician, or the clin tech, or the person that cleans the room. And at Inova Fairfax, you defer to the experts all the time. I, as a leader, will identify opportunities, but the solutions to reduce that harm comes from the frontline staff. So at Inova, we have a True North board, and on the True North board are what we call A3s, which are lean tools to help us reduce harm and help us identify how we can mitigate that harm from reaching the patient again. And we can track and monitor, because as you know, anytime you put a process in place or a mitigating factor in place, you want to monitor that, and we can monitor that on a monthly or even a daily basis. So that I think is a real opportunity that we've done very, very well with the A3s at our True North board. The next one is preoccupation with failure. And you think about Murphy's Law, anything that can go wrong will go wrong. Mm-hmm. So we as leaders need to be preoccupied with failure. So constantly going out and rounding in our leader rounds, where the leaders in the organization round on the floor every single day, talk with the frontline staff, and better understand what is going on so we can understand those processes, figure out what can happen, what has happened, what normally happens, where's that gap, and try and close that gap. For a frontline person, the preoccupation with failure comes in with the ability to walk into a patient's room, scan it, and know exactly what's wrong right when you walk in the room. So for example, if a patient has a Foley, and there's a loop in the Foley, well, that can cause a CAUTI. So we want to make sure there's no loops in Foleys.
And a Foley is a catheter, just for any non-medical people.
Yeah, a Foley is a catheter that drains the urine. Or a central line has some blood on the dressing, and that goes into the central part of the heart. That can cause a central line blood stream infection. So we want to be looking for those things. So a person that goes in the room, scans the room, they're going to be looking for these defects. The other one is reluctance to simplify. And so often something happens and we say, the answer is X. Well, you didn't go through the 5 whys to figure out why did that happen. And you have to go through a standard process to get to the bottom of the root cause before you really have that opportunity to understand what happened and prevent it in the future. And the last one is sensitivity to operations. And that one, that's about visibility, leadership visibility, out on the front line all the time, connecting with the frontline staff, understanding what is going on, what barriers do they incur every single day, and how we as leaders can help remove those barriers so that they can achieve high reliability and get the reduced harm for our patients.
So it sounds like that you're really connecting your frontline workers with your leadership. You're creating an atmosphere where people can bring forward either near misses, or true problems.
Yes.
So both of those things sound great. So we have about 5 minutes left. So what are some of the other things that keep you up at night related to patient safety?
Okay.
Or on your pathway to becoming a high reliability organization?
Melissa, I think some of the things that keep me up at night are the workarounds. Staff, we have an event, you go through an event analysis, and first you ask is what happened, and then you ask what normally happens, and then what should happen, and then understand why it happened, what are you going to do about it. But the gap between what normally happens, and that's the workaround, and what should happen, which is the policies and procedures, the wider that gap is, the greater the opportunity for a harm to occur. And the more workarounds that you have, the more likely that a workaround will result in harm reaching the patient.
And is that because different people have different workarounds, or?
Different people have different workarounds, yes. And just take for example, we have a process in place for a 2-patient identifier. Every time you identify a patient, you use their name and birthday to identify them, or their MRN, whatever it is that you're using. And if you don't use both, chances are you could give the wrong medication to the wrong patient. And the workaround is, well, I'm busy, I'm just going to go use the name and say, and that's it. Well, there are a lot of people in the hospital with the same name at the same time. And the only thing that distinguishes them is their birth date or their MRN. So you really have to use that 2-patient identifier.
And an MRN is a medical record.
Yeah, well, I'm
number.
sorry, yes, it's a medical record number, yeah. So,
So, what are some of the other things that keep you up at night related to patient safety?
So every time you identify a patient, you use their name and birthday to identify them, or their MRN, whatever it is that you're using. And if you don't use both, chances are you could give the wrong medication to the wrong patient. And the workaround is, well, I'm busy, I'm just going to go use the name and say, and that's it. Well, you know there are a lot of people in the hospital with the same name at the same time. And the only thing that distinguishes them is their birth date or their MRN. So you really have to use that 2-patient identifier.
So, right, so part of becoming a high reliability order, when you talk about the process of actually performing whatever healthcare activity you are, is so that everyone's kind of doing the standard approach, which minimizes the opportunity for people to deviate from that.
Right, right. You know, we talked a little bit about high reliability and what it is. You know what it's not? It's not an event. It's not a project of the month. It's not the flavor of the month. It's really an organizational commitment from the top down and bottom up to become a high reliability organization. It's transparency at the transactional level, right at the front line. Everybody knows what's going on. And sharing that and developing that shared mental model around high reliability. And you know, you add into that the tactical tool of team steps, I think Dr. Murphy is going to talk about in a little bit, and our just culture. As we move our culture, you can change the beliefs of the organization, which ultimately impacts the actions and results, the outcomes. So as you move your safety culture along in a positive direction, or your culture of safety in a positive direction, then your ability to get to a high reliability state, because it's not an endpoint, a high reliability state, then is much improved.
So is this commitment to becoming a high reliability organization, is that something that every hospital does or is expected to do?
I think that it is an opportunity for the entire health system in the United States to move towards high reliability. The process by which you do that, I think, varies amongst the hospitals. We're not regulated to become a high reliability organization. However, the goal to get to zero harm cannot be done without doing the work that high reliability organizations do, and that's reduce the clinical variation at the bedside through process standardization, and that ultimately reduces morbidity and mortality.
Okay. So I think all of this is great. Are there any kind of final thoughts that you would like to share with us in our last minute?
You know, I think that that the work that we've done over the last 2 to 3 years at Fairfax and at Inova Health System around the triad of high reliability, team steps as a tactical tool, and just culture, using our patient safety surveys and our engagement surveys to help measure where we are going along in our journey, I think is a great monitoring tool for us to see if we are getting where we need to go. And you know, a great proxy indicator for high reliability and our safety culture is hand hygiene. And hand hygiene really is a proxy indicator for where your culture of safety is. Because if you're washing your hands, you will reduce harm, and you've really changed that culture.
Yeah. So thank you all for being with us. When we come back, we'll talk about some other initiatives Inova has, including medication errors and falls. And starting July 10th, Inside Scoop will be live at 8 p.m.
There's more than just books at the library.
There's more than just books at the library.
Excuse me.
There's more than just books at the library.
Il y a plus que de livres à la bibliothèque.
Hello. You have a lot of great books here today. You know there's more than just books at the library.
I know.
There's more than just books at the library.
I don't want to be hooked to a machine.
I want all the medical treatment available to me.
I wouldn't want my family to have to make this decision.
My doctor knows what's best for me.
An advance directive is your life on your terms. Talk with your family. Decide what's right for you. Then put it in writing.
Documenting my wishes today means my family won't have to make heart-wrenching decisions later.
To learn more, visit www.putitinwriting.org.
1,200 American youth run away from their homes every day. The National Runaway Switchboard is here to help. 1-800-RUNAWAY. If you are a runaway, thinking about running away from home, or a parent or guardian concerned about issues facing your child, call us 24 hours a day. 1-800-RUNAWAY. In times of crisis, hope is just a phone call away. 1-800.
We're back to the Inside Scoop. Here again, your host.
Welcome back to the Inside Scoop. I'm your host, Melissa Batchelor-Murphy, for the healthcare series that we're doing monthly with the Inside Scoop. I'm joined now by Kathy Helak, who is a nurse and the Director for Quality and Performance Outcomes at Inova Fairfax. So thank you very much for being with us this evening.
Thanks so much for having me.
And I hear that you are helping to direct a really innovative, high-quality fall prevention program. And so...
yeah, so happy to talk about the great work that's gone on at Fairfax, which is really a multi-pronged approach requiring the entire team, nurses, physicians, respiratory therapists, physical therapists to be involved. But how we got on this journey is really about the staggering statistics associated with falls across the country. So when you think about falls and fall-related injuries, patients who are 65 or older are very high risk for that. And in fact, that's one of the top reasons that patients 65 and older are hospitalized. We also know that 50% of patients who come into the hospital are at risk for falls, and 15% of that population will experience at least one fall while they're in the hospital. So it's very concerning to us, and we don't want to contribute to those statistics. So at Inova, we've been really working as a multidisciplinary team to make sure that every single person who works there, that touches a patient, that supports taking care of patients in any way, whether it's the nurse, the physician, the environmental services worker, the dietitian, is mindful of how important it is for us to keep our patients free from falls. Falls can be associated with patients in the hospital with extended length of stay, increased costs, and sometimes very serious injury or even death. So we want to break that cycle.
Right. So what are some of the different initiatives you have to actually make that happen?
Well, there's a lot of things we've done, and again, falls is really a multifactorial problem, and it takes a wide variety of tactics to make sure that we're covering all of our bases. So just to touch a little bit on why patients fall and why patients are at risk when they come into the hospital. You know, anybody who has increasing age is going to have more health problems. There may be medications that make them more vulnerable to falling. Their frailty, their weakness or strength level, these are all things that can contribute to patients falling out in the community. And when they come into the hospital, that's just compounded by the fact that they're sick, they're stressed, they're in a strange environment. There may be factors such as pain or additional medications that put them more at risk. So we look at all of those things, and the first thing that we do with every single patient that comes into the hospital is a thorough assessment of their risk for falls. So whether you're a mom coming in to have a baby, you're a patient coming in for surgery, you're coming to our emergency department, or you're coming in with a serious illness, you are going to be assessed by your nurse to make sure that we understand what are your risks for falls. That's not done just when they enter the hospital, but every time the change of shift occurs or when a new nurse comes on to take care of the patient, we do that assessment. So every day the patient is assessed, and that's to make sure that that risk hasn't changed. It might have lowered, and so we might change some of the interventions we're doing for the patient, or we might have to add more interventions to keep them safe. So I'm so glad to talk about some of the things that we've done at Inova, because I think that we are really on the cutting edge. In addition to that assessment, we use technology. In the last year and a half, we have added technology that we can move into the patient's room to assist with gentle reminders through remote staff, talking to the patient if they're trying to climb out of bed. So sometimes patients are confused, they can't remember all the things that we're asking to do while they're in the hospital. So that gentle reminder just is there to say, you know, Mrs. Murphy, don't get out of bed, let me call your nurse for you and she'll be right in to assist you.
And when you say remote, this is one person who's watching multiple?
Yes, we have a team of staff that can sit in a room away from the patient's rooms, often another area of the department, that can watch several patients and provide that gentle reminder to them. In addition, we have smart beds. Like we are used to having smart technology now. Each room is equipped with a bed that provides a bed alarm. And so for patients who are high risk for falls, we have a bed alarm that alerts the nurses and the entire team out in the department when the patient is moving around in bed or might be getting out of the bed. And that is just a way for us to make sure that we're all front and center paying attention to patients who are at risk so that we can attend to them very quickly and prevent them from falling out of the bed and harming themselves. We have a lot of other neat things we do. Hourly rounding is a critical step that we do. Our nurses and our clin techs go in and check on the patients each hour, not only to take care of any of their needs, but also to scan that room and to make sure if the bed alarm is supposed to be on, it's on. The things are out of the way so that they're not, there's not clutter that could cause them to trip or fall, to make sure that they have their call bell, to make sure that they have their glasses so that they can see. And so creating a safe environment for the patient to be in while they're hospitalized is very important because they're out of their element. So those are some of the things that we're doing. We also have put a lot of focus on patients and families and how they can really be involved in helping us to keep the patient safe. So, you know, on a daily basis, front and center is talking with the patients about why we have a fall prevention program in place for them and the different interventions that we are doing to keep them safe. We also talk with family members about the do's and don'ts of what they can do to help us to keep the patient safe. So, for example, it's important. We love to have families come and spend time with the patient. That's so important. But when they get ready to leave, it's important for them to let us know that they're leaving the room so that we can just be more mindful, again, that the patient is now without their family. Another important step for them to do is to make sure that they help us to understand, does the patient have any history of falls? Oftentimes with our elderly patients, they can't tell us if they have a history of falls, but the family can, and they can tell us what might have contributed to that. That can be really valuable to us in terms of understanding what's going on in the hospital. We also like to make sure that our patients' families know what they shouldn't do while they're visiting in the hospital. One of the most common reasons patients fall is trying to get up to go to the bathroom. And for patients who are high risk of falling, who are frail, who need assistance, they really need to rely on our staff to help them to go to the bathroom. And that's why we have the bed alarms in place, that's why we have call bells in place, so that patients can call out to us and we can come to their needs immediately.
And it takes all three of those because maintaining your independence is one of the things all of us wants to do.
Absolutely, absolutely. And a lot of times patients, I just didn't want to bother the nurse. You know, they've been so great, I just didn't want to bother them. But that, we want to be there. We want to really keep the patient safe. And we emphasize that each time we're talking about the fall prevention program for that patient, how important it is that they call us, that they let us know, you know, anything that they need, and that they understand our most important goal is to keep them safe while they're under our care. So we really ask families to make sure that they call us when the patient needs to go to the bathroom versus them trying to help. And we can find other ways that families can be helpful to us and to support their loved one while they're in the hospital. But it's so important that they rely on us for some of those important things that keep patients safe, and particularly with toileting patients who are weak and frail, may not be able to, you know, ambulate by themselves. We need to be there to help them.
Yeah, I think family members often don't understand what goes into helping someone to get to the bathroom. And if you have two people that are frail trying to help each other, you're going to create more of a problem.
Right.
But you had described a brochure also that you guys had put together.
We do. We did. About a year ago, we decided we needed to educate families more effectively than we had been. And we actually reached out to our Patient Family Advisory Committee at Inova Fairfax Medical Campus and asked them to help us design that to make sure that it really was going to state things in a way that would get the point across to families. And so it was really helpful. We were starting out with, some nice pictures and things that looked very aesthetic, and our committee member said, absolutely not. It's important that families understand, your fall prevention program and really all those do's and don'ts. And so based on that, we put a new brochure in place, and it's made a significant difference in terms of our families understanding those do's and don'ts. And all of these interventions that we put in place over the last year and a half led us to about a 30% reduction in falls in 2016, which we're really quite proud of. That's a significant accomplishment because when you look at falls across the country, most hospitals aren't achieving that level of success. We still have work to do, and we are seeing some nice reductions this year and are continuing to look for ways to improve by looking at technology, reaching out to patients and families for what they can help us to learn so we can improve, and continuing to keep very mindful as a healthcare team on the importance of fall prevention.
So that's great. So we just have a few more minutes left. So is there any final thing you would like to highlight about the work you're doing related to falls?
I think just to emphasize that this is a serious problem across the country. People fall outside of the hospital. We want to make sure that we put all the safety nets in place to protect patients when they're very vulnerable in the hospital. This is a journey, and we continue to look for new and more innovative ways to prevent falls. But I think we've made some great strides, and we have our patients, our families, and our staff and physicians to thank for the good work that's gone on at Fairfax.
Well, that is fantastic. So it is great to hear about the work that you're doing related to falls, and we're going to continue our conversation talking about medications and reducing medication errors, as well as talking about different ways that the team can communicate. And I think a lot of what you have just explained really kind of exemplifies that work.
Absolutely. Medications can play a big part in putting patients at risk for fallings, and communication is essential so everybody is on the same page in terms of keeping the patient safe.
So thank you very much for being with us. When we come back, we'll be talking about reducing medication errors as well as improving team communication. And just a reminder that starting July 10th, Inside Scoop will be live at 8 p.m.
Listen to smoke before you give it a try. Only you. Don't play with matches. Don't play with fire. Cause there's nothing very funny about ring-top, nothing very nice. Hole is mine. So if a gorgeous force is what you desire, don't play with matches. Don't play with fire.
Only you can prevent wildfires.
Fire.
Why don't you just wash your car at home?
When I wash my car, everything runs down the street and down into the storm drains. With all the chemicals in the soaps and waxes, the last thing I want to do is poison my own drinking water.
At least here, it's all contained and recycled on site.
That's why I also take my car in for oil changes instead of doing it myself. I might take a chance on spilling stuff.
You know what the best part is? What? More time to kick back and watch the game.
How far would you go to protect the planet?
I want you to build an ark.
Here we go. Okay, that's good. Oh, okay. Ow!
Maybe there's another way.
People, the flood is imminent. Is it too much to ask for a little precipitation?
Go to fightglobalwarming.com to find out what you and your community can do to reduce global warming pollution.
Somewhere around the world, there are men and women of the armed forces risking their lives, helping rebuild communities after natural disasters, collecting toys for needy children, tutoring kids in school. These are your sons and daughters who work to keep us safe, secure, and free. Dedicated men and women who put their country first.
We're back to the Inside Scoop. Here again, your host.
So welcome back to the Inside Scoop. I'm your host, Melissa Batchelor-Murphy, and we're doing a monthly healthcare series, and we're continuing our discussion around patient safety and some of the initiatives that Inova Fairfax is doing and Inova Health System related to improving patient safety. So I'm joined now by Ms. Patrice Dupart, and Patrice is a pharmacist by background, so you're PharmD, yes. And so maybe you can tell me about some of the work that you're doing with reducing medication errors.
Okay, first off, in the hospital, the pharmacists are involved with patients across the continuum of care. And the pharmacists are responsible for all the drug therapy that a patient will receive in the hospital. We're there to ensure the right dose, the correct time the medication will be given. We're there to ensure that patients get the right form, whether it's going to be a pill, whether it's going to be an IV. And we are also there to ensure that whatever the physician prescribes, it doesn't have any allergies associated for that patient. There aren't any drug-drug interactions, as well as any potential side effects. So really, pharmacists control the medication use in the hospital to make sure that's safe. What we've done is really try to create a multidisciplinary team that's working together to make sure we have safe medication use. When a physician initially prescribes a medication, he most of the time knows exactly what he wants, but in some instances he may refer to the pharmacist to ask, hey, is this the best drug I can possibly use? And we do have some really excellent clinicians who are out rounding with physicians and really guiding them on the appropriate doses. We have, like physicians have specialists in oncology and cardiology. Pharmacy has gone by the way of having specialists in oncology, cardiology, transplant, so they help in to guide that therapy. And we also are there for the nurses as well to answer any questions that the nurses may have. Our pharmacists are strategically located on the medication unit. So if the nurses are administering a drug to a patient and they have questions, they can just turn and ask the pharmacist, about that particular drug therapy. So it's called like a decentralized model. It really benefits our patients and our clinicians to have pharmacists up front and very close to the patients.
Yeah, it's a very different model than what I'm used to being primarily in nursing homes where the pharmacist comes by once a month. So,
yeah.
So it's great that you're able to do that. So what are some of the particular things or programs that you're doing?
One program that we have to make sure that our medications are dispensed safely, because we have a pharmacy that's in-house in the actual hospital. Not many people get to see the pharmacy. It's strategically located to make sure our medications are secure and kept away from the public. But we have such initiatives as barcode scanning. What we do, every drug that we purchase has a barcode on it that associates that drug with the actual dose, the name of the drug, the expiration date, everything associated with that drug entity. So what happens is that a pharmacist will barcode scan that drug after we have identified that the doctor has written that prescription for that patient. So once we barcode that drug with that patient label, it connects them together. So if Patrice was ordered a 50 milligram, let's say, or I'll use something more generic than that, like Tylenol 500, and so they'll barcode scan that actual medication, and then they'll barcode scan my label, and it says, yes, that drug is correct for Patrice Dupart. So we do that in the pharmacy, and we also have that externally on the nursing units. So when a nurse gets that drug up on the unit for the patient, she will take that exact same drug, scan it, and then each patient has a patient armband that identifies them. Patrice Dupart, date of birth, medication record. So she scans that drug and then connects that drug to Patrice Dupart on the unit. So we have those both internally in the pharmacy and then external on the unit to ensure that that patient's going to get the correct medication. That's a big deal for us to make sure we have those checks through the continuum.
Right, I think that goes back to what Dr. Betzelos was saying about high reliability organizations having that process in place.
Yes.
It also helps cut down on kind of that human error, but I'm going to take a shortcut, and you've kind of put that in place to make sure it can't happen.
Yes, and it is a standard process in the pharmacy, how we're to do that, as well as on the nursing units. They have a standard process. Another thing we do is everything that leaves our pharmacy department has to be double checked. We have technicians that work with the pharmacist, and so the technician will be sometimes the first person to either compound the medication or actually get that drug to dispense, but it's a pharmacist that has to check every dose that leaves that pharmacy department. Sometimes it's tech pharmacists, or sometimes it may be a pharmacist to pharmacist for some things that we considered are high risk or high acute type medications. So that's another step. We do sometimes specialized labeling to make sure that those medications like anticoagulants, most lay people in the public know them as blood thinners. We put, high risk, we do like bold type, we may change the label to make sure that we know, as well as the nurses know, that they should take special care. And
I think you call that a letter.
We use tall man lettering.
Yeah, tall man lettering.
And tall man lettering is kind of like you want that drug to, the spelling of that label to pop out. So you kind of capitalize those things that let you know that it's different. Like for heparin, you probably do capital HEP. Hey, this is heparin, so the nurses can differentiate. But speaking of blood thinners, that's one drug that the nurses will do a double check with another nurse on the unit before they actually give that drug to a patient. So if that nurse is going to give any respective blood thinner, she has to get another nurse to come and check and look and say, hey, yeah, that's the right heparin dose for Patrice, and you can go have it and administer it after she's co-signed that that's the correct dose. So that's another step in keeping our patients safe.
Yeah, I even heard something recently where if you didn't have enough people in-house, that second check could be done remotely, just like we were talking about with the patient fall. So it's so interesting to me to see how technology is playing into keeping patients safe.
Changed the whole ball game for healthcare in terms of having a electronic medical record to have, just like you described. Pharmacy has this practice in some facilities where you have remote order entry, where we can remotely look at that patient's record and what the physician is prescribing for that patient and verify that it's okay. So, having a technology really has advanced our practice.
So that is great, because even when you're tired, if there are certain things that can help you to double check to say, I think I just read the word heparin, but maybe I read something different.
Sometimes you see what you want to see, and so to have those extra set of eyes is always helps us with the keeping the medication safe process.
Okay, so we've talked about the double check in the pharmacy, the decentralization of the pharmacy. So are there other initiatives within?
Yeah, in fact, we started it's an initiative, maybe it's been about a year old now, and what happens is a lot of times patients come to the hospital, be it emergency, or sometimes it's planned surgeries, but when they come to the emergency department, we have strategically located technicians in the emergency department, so when that patient, Patrice Dupart, comes to the hospital, the technician will get my medication history, and we want to know exactly what medications those patients are taking while they're outside, so we can have the physicians make sure they prescribe them that medication while they're in the hospital. So oftentimes patients will come, they don't have their medication list, or sometimes if they're coming through the emergency department, they may not be able to tell us.
It was an emergency.
Yeah, it was an emergency. Or they family members.
At home.
Their family members may know. So we have technicians who will take that medication history from the patient, and if they don't have their medication card with that list, they will call our respective pharmacies. They will contact their relatives. They would do whatever it takes to make sure we have a good, clean medication history. So when the physician decides to write those medication orders for the patient in the hospital, he has a good, comprehensive medication list for that patient. So it really helps that we ensure that patients no drugs are omitted or the incorrect dose is given while in the hospital.
Right, and that process is called like a medication reconciliation.
Yeah, it's a med history, med reconciliation technician program. So it's been a huge service satisfier for the physicians as well as the patients and the nurses, because it makes their work so much easier once they actually have to write those, the physician has to write those drug orders.
So are the pharmacies outside of the hospital connected through like an electronic medical record, or you still have to kind of old school call them?
Sometimes we have to old school call them, but in terms of Inova Fairfax, we do have 2 what we call retail pharmacies that are located in our hospital. We have one in the emergency department, so if you come in our emergency department and you just have a short visit for some reason and you stay a couple of hours and then the physician write a prescription for you, you can get them filled right there in our emergency department pharmacy. And so you just leave the ED and get those filled. So it works for us because we're all on the same record. So those pharmacists who are in the retail pharmacy, they really get to know that, hey, the patient came because they had a broken toe or ankle, and so they need the physician prescribed the narcotic or what have you electronically, and it goes straight to that pharmacy. So it really works well because we have more of a closed loop system. You come in and you get to, even if you're inpatient, when you leave, you can leave with your medications as well.
So you've described that kind of coming in, but is that a process that happens kind of each time they move to a different part of the hospital?
Pretty much. Pharmacy touches patients through the continuum. Like I said, we have those med history technicians in the emergency department, and then while they're in the hospital, we have what we call inpatient pharmacists who are working on making sure those patients get all those doses when they're on the unit, and they're decentralized and making sure that they have answer questions for the nurses and the physicians. And then we also have a transitions of care pharmacist program that we recently started, and that's a big one for us. It's a huge benefit for our patients. So this transitions of care pharmacists, what they do, they, once the physician prescribes the prescriptions to leave, they go and they talk to that patient and they'll say, hey, Ms. Dupart, I'm your pharmacist and your physician has written these prescriptions, and they'll go through, very detailed instructions on how to take it, what potential side effects they may experience. They may, let them know when they're supposed to take the medication, any drug-drug interactions they foresee with the other medications.
Or even drug food.
Yeah, drug-food interactions. And so the patient gets an opportunity to talk and speak with a pharmacist before they actually leave the hospital. We do have data to show that when a patient has that discharge counseling and med reconciliation done by a pharmacist, it prevents them from being readmitted to the hospital a lot of times, for particularly like our Medicare-focused patients, within 30 days or within a short period of time.
So that is a great support in nursing, what we kind of call transitional care.
Yes,
so,
absolutely.
Yeah. So thank you very much for being with me this evening and sharing all the great things they're doing around medications. When we get back, we'll talk about improving team communication. And just a reminder that starting July 10th, the Inside Scoop will be live at 8 p.m.
Take a look under your bed. Find stuff under there? What about jobs? No? Now try your closet. Still no jobs? Just more stuff? Well, you really have both. See, stuff is defined as household articles considered as a group. Sometimes this stuff is no longer needed. Wait, no longer needed? That can't be right. Because remember those jobs you were looking for? Those are really needed. And they're the stuff inside your stuff. Our job is to unlock those jobs. And it starts when you donate your stuff to your local Goodwill. Here's how we do it. When you donate to Goodwill, we sell your stuff to provide job training for people right here in your community. So just by teaming up with Goodwill, you help create jobs. And isn't that worth parting with the leftover keytar from your 80s cover band? Goodwill. Donate stuff, create jobs.
We just finished dinner and it was time for homework. He hates homework. I know he's bright.
Why is it so hard for me?
He's just gotta
as
try a
hard
little
as
harder.
I can.
1 in 5 children struggle with learning and attention issues. Go from misunderstanding to understood.org.
It's me, Artie. Come see what I collected from the creative galaxy in my idea box.
Transform your world.
Will you help me make art?
Each one of our journeys keeps us.
Before you throw it away,
Hey, I have an idea.
think outside the box.
We'll never get older. Each one
Go be amazing!
Give your cardboard box another life. Recycle.
Most party fouls, not a big deal. But if you decide to drink and drive underage, you could lose your license and your freedom. Underage drinking and driving, the ultimate party foul.
We're back to the Inside Scoop. Here again, your host.
So welcome back to the Inside Scoop, and we're doing our healthcare series on patient safety. June is National Patient Safety Month. So I'm joined now by Dr. Charles Murphy, and he is the Chief Patient Safety Officer for Inova's Heart and Vascular Institute. And so your expertise is around improving communication among the healthcare team. So maybe you can tell us a little bit about what Team Steps is.
Right. Well, we've embarked on team training for our entire staff at Inova, and the team training that we do use is called Team Steps, which is an acronym that stands for Team Strategies and Tools to Enhance Performance and Patient Safety. And it actually originated from the crew resource management with commercial aviation, and they've really been very successful in improving their teamwork and communication, as well as their safety record using the crew resource management. If your viewers think to the Miracle on the Hudson, I think everyone's aware of that and the tremendous job that they do. And so we've really taken that and are using it in healthcare. And Team Steps consists of 4 teachable, learnable skills. So those are leadership, communication, situation monitoring, which then allows for mutual support. And so those are sort of the 4 key elements of teamwork. And this is true not just of medical teams. This really applies to any type of teams, whether it's a professional sports team or a restaurant or a military team. These strategies and tools really have been developed across these different areas. And so what we're trying to do is really optimize teamwork and communication amongst a very complex team in healthcare. So my elevator speech is better teamwork, better communication. And one of the reasons for that is we know that when you look at medical errors, 60 to 70% of the time those involve breakdowns in communication. And that's data from the Joint Commission, which collects that information. As well, we know that when we survey healthcare workers, or when you actually have experts come in and observe teamwork, that there is opportunity for improved teamwork in the healthcare sector. And so we've really embarked on training really all 8,000 members of our workforce in how do we provide excellent teamwork and excellent communication. So we're very excited about that.
So part of the Team Steps is around these strategies. So what are some of the strategies that you're teaching people to do?
Right. Well, I'd say that one of the things for me is that there are these critical principles. And so one of the things is that we want to have a shared mental model for that patient that's in the hospital. If your mother is in the hospital, we want to know exactly as a team what we're planning to accomplish for that patient that day. So again, this is a shared mental model. I think one of the other critical aspects is referred to as psychological safety. So we want every single person on that team to feel comfortable speaking up if they see an issue related to patient safety or quality. Interestingly enough, Google examined their teams. It was something called the Aristotle Project, and they found that the single most important factor for having an effective team was this concept of psychological safety. And so we really want to instill that on our teams. And And we've seen some success with that. One of the environmental service workers on my intensive care unit actually spoke up because of her concerns and actually prevented a patient fall, again, because she is, even though she's an environmental services worker, felt comfortable of calling out to the team and letting us know that there was an issue. So that's really what we're striving for, where we're all working together. I think one of the other things is that it's a complex network of teams. So we have an emergency room, we have pharmacy, we have the intensive care unit, and yet we have to have those different teams work together and coordinate their care, and even now extending into the outpatient world, where we want to team with those providers and teams to provide the optimal care for patients. So this aspect of having excellent teamwork and excellent communication in a very complex environment is one way that we can get to those to that highly reliable organization. That's the goal that Dr. Betzelos talked about earlier.
And so I think communication can be either verbal or nonverbal. So do you work on both aspects of that?
Well, I think, it's a great point. We do tend to work more on tools to make certain that communication is done well. So we want communication to be brief. We want it to be timely. And there are some tools that we utilize. One of the favorite tools is one around it's called cuss words, not the ones that your viewers think about, but it's "I'm concerned," "I'm uncomfortable," "this is a safety issue." And so that's an example of one tool around communication. Another tool around communication is called SBAR, and many nurses are familiar with that from their schoolwork, where they communicate with another provider, a physician, and say, this is the situation, this is the background, this is my assessment, and this is a recommendation. So it's a way of having standardized communication. We've also, with our restrictions in healthcare, et cetera, handoffs become extremely important. And just like we don't want the Washington Redskins to ever have a fumble, we don't want our healthcare workers to ever have a fumble in terms of safely handing off that patient from one area to another, like the emergency room to the intensive care unit, or from the operating room to the intensive care unit. And I'm happy to say that when the Joint Commission recently visited our hospital, they actually identified our handoffs from the operating room to the intensive care unit as being extremely well done. So, I'm very fortunate. We work with exceptional teams at Fairfax, but we're also very passionate about feeling that we can always be better. And so that's one of our goals. I think one of the other things we have at Fairfax is we have two simulation facilities. And so, of course, simulation is great because it allows us to practice these skills and practice not only the teamwork skills, but also the technical skills in a safe environment. So we're not going to harm a patient in a simulation environment. And so simulation is a very powerful tool to help us do this type of training in a very safe environment. And we were able to just present in the last few weeks at the National Team Steps meeting about some of the ways in which we're using simulation to enhance teamwork training.
So just for viewers that maybe aren't familiar with simulation, maybe explain a little bit about what that is. I know that we have a simulation lab in our School of Nursing, so maybe you can just explain a little bit about what that means, since we're communicating.
Right. Well, and so I think people maybe are familiar with simulators when it comes to flying a plane. Mm-hmm. And in a way, this is no different, but this is designed towards healthcare. So we literally have these mannequins now that are amazing now. They'll open their eyes, they breathe, and they can be programmed in certain ways. Again, you can have the monitors with the heart rates and the blood pressures, et cetera, and you can actually program in different problems that clinical teams may face and practice to make certain that what you do technically is the appropriate thing, as well as that you have great teamwork and communication. And that's sort of it. And we actually can film those episodes. And then one of the important aspects of that is doing what's called a debrief. So actually, after you have the simulation, for several minutes, you actually spend some time talking about what went well, what could be improved upon so that you can get better as a team. And that's sort of a high fidelity level, but you can also have it all the way down to low fidelity simulation on an individual patient care unit without sort of all the glitz of the fancy simulation. So there's a whole range of simulation that's available. And we have Dr. Emily Marco is a leader of one of our simulation areas and really does an exceptional job with helping us with that program.
So it sounds like you've mentioned some strategies, and you've mentioned an environment in which you can do your team steps training. Are there any other parts of team steps that seem to improve communication with different teams? You've mentioned the shared mental model.
Right. And so there is, I think, with regards to communication specifically, we're always trying to have closed loop communication. So we want to make sure that someone communicates to someone, but that also that message has been received and that that's communicated back to the sender. So an example of poor communication, which people with teenagers will be familiar with, is texting. So when you text someone, you don't really know whether that communication has been received or not. Until you actually, if I tell my teenager we'll be home at 10 o'clock, then if they repeat back, oh, Dad, you want me home at 10 o'clock, and I say yes, then you've made it safe communication. And that's what we're really striving for all of our health care to be, is very closed loop communication. And so Team Steps, part of it is actually having a set of tools within all those 4 teachable, learnable skills that help the healthcare team function at that higher level. So 2 of the tools are briefs and huddles, where the teams actually come together as a team and we actually share that critical information, much like the Washington Redskins huddle up when they start a play, so that every single player that's out there on offense knows exactly what the plan is. Obviously the goal there is to score a touchdown, and our goal is for the patient to have the service that they need, such as an operation, but to leave the hospital doing extremely well.
And I think that particular part is one thread that's come through all of the segments tonight. Dr. Betzelos talked about having the rounds where people got together, and I would assume that that's for like a huddle or a brief. The same thing with the fall rounds, and then even with pharmacy. So that's great. It sounds like that's a very, very effective strategy.
And our emergency room is doing some great work around sepsis. And so we do sepsis huddles in the emergency room so that when that patient comes in who potentially has sepsis, as many of your viewers will know, time is imperative. So we really want to get that patient antibiotics as quickly as possible to treat that infection.
Okay. Well, thank you very much for being with us this evening. And just a reminder that starting July 10th, Inside Scoop will be live at 8 p.m. And you're welcome to watch any of these segments on my website at melissabphd.com. And we thank you for being with us this evening.